Thank you very much for the invitation. It's a pleasure to be here and talk about this interesting topic. Hey Crow, my friend, thank you to organize this amazing event. I don't have conflicts to declare for this presentation, and my talk will be divided in 4 moments: introduction, preclinical models, clinical data, and final considerations. CDK inhibitors can be considered standard of care for breast cancer patients with hormone-positive and HER2-negative disease for both metastatic setting and also for early-stage breast cancer at high risk of recurrence. Radiotherapy is one of the most widely used local treatment for breast cancer patients. And after breast conservation surgery, postoperative radiotherapy is associated with improvement of breast cancer death rates. Moreover, after mastectomy for locally advanced disease, postoperative radiotherapy is associated with improvement of local regional recurrence and breast cancer mortality rates. In metastatic setting, radiotherapy can also be used for palliative or biological ablative intent. So, in clinical practice, how should we combine CDK inhibitors with radiotherapy? Based on preclinical models, CDK inhibitors can induce G1 cell cycle arrest, impairing cell cycle progression. And there are different models that can try to explain this relationship. First, CDK inhibitors can improve the effect of radiotherapy based on cytotoxicity event. The cytotoxicity event of radiotherapy is cell cycle dependent, and cancer cells are more sensitive in G1S and G2M transitions. It means that concurrent CDK inhibitors and radiotherapy might result in a higher percentage of G2M cells, being a synergistic effect of combination. The second mechanism is genetic knockdown of CDK inhibitors confers radiosensitivity in breast cancer by inducing an apoptotic program, arresting tumor growth. And finally, CDK inhibitors cause quiescence in normal tissue, protecting against common side effects related to the treatment. On the other hand, proposed mechanism of tissue damage when combined CDK inhibitors with radiotherapy were also described, and these mainly be associated due to lack capacity to DNA repair and also due to the local immunity response that can cause tissue damage in the radio field. More details about the preclinical models will be presented today after lunch. Let's move to clinical data. CDK inhibitors in clinical trials for adjuvant treatment. In Monarch A, patients were randomized to receive endocrine therapy versus endocrine therapy plus abema. The 5 years invasive disease-free survival was improved in abema group. In this trial, 95% of the patients received postoperative radiotherapy, and the radiotherapy should have been completed prior to the enrollment, and also a one-shot period of at least 14 days was required between the end of the radiotherapy and the trial randomization. The authors demonstrate the side effects related to the treatment, and as we can see here, the risk of radiopneumonia was low in both groups. It means that the concurrent administration of radiotherapy during adjuvant abema might be feasible approach. deserving investigation in the next future. In Paula's trial, patients were randomized in endocrine therapy versus endocrine therapy plus palbo. This is a negative trial, but when you look to the radiotherapy approach, almost 90% of patients receive palbo. And again, in this trial, the CDK inhibitors must be used after the end of radiotherapy and must have sufficient resolution of side effects related to the treatment. In Nader trial, patients were randomized to receive endocrine therapy versus endocrine therapy plus HIBO. The invasive disease-free survival was improved in the HIBO group. The global benefits, the absolute benefits was 3.3%. And when we look to the side effects table, the risk of pneumonia was low in both groups. However, no information about radiotherapy is available about this trial. In metastatic disease, Paloma's trial, radiotherapy was permitted, and a formal recommendation to suspend palbo for 1 day before and 7 days from the day prior to radiotherapy course was formally described. In Mona Lisa trial, palliative radiotherapy was permitted to treat bone pain metastases, and it should not be delivered at the target lesion, and it should not encompass more than 25% of irradiated bone marrow. Taken together, all these trials demonstrate that the most frequent side effects, grade 3 and 4, related to the treatment were myelosuppression, fatigue, nausea, and vomiting. None of them directly related to radiotherapy. Based on that, no information on concurrent treatment was available in pivotal randomized trials. Our group developed a systematic review and meta-analysis about this issue, and this study was accepted for publication in Cancer Treatment Review. This study aimed to assess the safety of combination radiotherapy and CDK inhibitors in breast cancer patients. The primary endpoint was toxicity equal or greater than grade 3. The second endpoints were association between radiotherapy and any toxicity, CDK inhibitors dose reduction rate, and CDK treatment discontinuation rate. It's important to highlight that radiant was defined concomitant if CDK inhibitors were used within its 5 half-lives. In a total, 11 retrospective studies were included. Let's move back. 382 patients receiving concurrent radiotherapy on 658 lesions were assessed. A median report follow-up was 12 months, and all studies report metastatic disease only. In this table, we can see the characteristic of the included studies. As you can see here, the limit number of patients were included, different treatment sites, and also different dose and fractions were used in these reports. The risk of bioassessment is summarized in this table, and 10 studies were classified as having moderate or high risk of bias, and only one study was classified as having low risk of bias. In this forest plot, we can see the grade 3 or more toxicity from the concurrent treatment. And the incidence of all grade 3 or more toxicity was 22%. And the incidence of grade 3 or more hematological toxicity was 14%, mostly represented by neutropenia. However, this event did not cause discontinuation in most patients. Only one patient needed definitive suspension due to side effects related to neutropenia. This forest plot demonstrates no hematological toxicity, and the incidence of grade 3 or more no hematological toxicity was 3% only, mostly due to gastrointestinal side effects. Radiotherapy on intracranial disease was reported in 7 studies with a limited number of patients. One study showed the results of radiosurgery, and 6 studies did not specify radiant technique or fraction. Globally, the incidence of radionecrosis was 2.6% only. Another concern can be related to the side effects is dermatological toxicity. In this case report, metastatic patient received 6 gray in 30 fraction, and after 20 fraction, this patient developed a grade 2 toxicity, and this patient required hospital administration due to worsening radio skin toxicity. It's another case report that demonstrates that this patient received 20 gray in 5 fraction with palbo. In 4 days after completing the treatment, this patient developed an unusual skin toxicity. There's a list of ongoing trials that combine CDK inhibitors and radiotherapy, and we hope that those trials can add more evidence on the safety of concurrent administration of CDK inhibitors and radiotherapy. So, in conclusion, the combination CDK inhibitors and radiotherapy for adjuvant setting lack data are available, and the combination should be avoided in clinical practice. In metastatic intracranial disease, limited number of patients were evaluated, and definitive conclusion on the safety of combinatory approach cannot be concurrently provided. And in the metastatic gastrocranial disease, most frequent report toxicity was hematological, and due to the low number of patients, definitive conclusions cannot be achieved. However, available data are encouraged, and the combination might be saved. This is the results of the final statement of our consensus. No details I'll be present because Ikro in the end of this event will show what the panelists think about this topic. Thank you very much for your attention.